Thank everybody for coming. We had our first Gamma Knife was purchased in 2003, and so what I'm going to do is do a little bit of historical stuff, and I want everybody to know how the Gamma Knife works and what it is so that you'll know what the new one is. So before we see the sequel, we have to see the prequel. So, all right, so Gamma Knife. It is not a knife. It is the gamma part refers to a ray. It's like an X-ray, but it's a ray that's emitted from a radioactive source. And in this case, it's cobalt-60. The knife part just refers to the precision with which the machine operates. It operates to an accuracy of 0.5 millimeter, so 0.5 millimeters. So we can sort of treat the left side of a line versus the right side. So it's a very, very accurate situation, but it's not a knife. It's just a phrase that was coined. The thing was invented by a neurosurgeon, Lars Lexell, back in the late 40s, early 50s, and he really invented it as a stereotactic way to deliver needles into the brain to ablate lesions. And it later became adapted to direct radioactive beams or radiation beams into tumors. So it's been around since the 50s, or the idea has been, and it was commercially available in 1968. And since he's Swedish, the Sofia Hemmet was the first place to get one in Stockholm in 1968. The first United States Gamma Knife was in Pittsburgh in 1987. That's where Dr. Kadis and I went and got our education from the guys that run that one up there. And in 1999, just to put it in perspective, London got one. They got their first one. And 4 years later, Thomasville, Georgia got one. And 7 years later, Paris got one. So just to let you know, this is a pretty technologically heavy hospital. We really do get technology in. So I think we probably are still the smallest city in the world with a Gamma Knife, I would dare say. So what this process is termed Stereotactic Radiosurgery, and that's the long words at the top there, and we shorten it down to SRS. And it sounds kind of fancy, but all it refers to is anytime you see the word stereotactic, it means three-dimensional or XYZ plane localization. So just refers to localizing tumors in 3 dimensions, the X, Y, and Z coordinates. And then, of course, the radiosurgery is surgery done with a radiation beam. So stereotactic radiosurgery means 3-dimensional surgery done with a radiation beam. And so SRS is a lot quicker to say. But the implication with the SRS is that there is maximum dose being delivered to a tumor and minimal dose being delivered to normal tissue. That's sort of the whole point of radiation treatment, but this takes it to its extreme. So the features of SRS: 3D localization, extreme immobilization. So when you are accurate to a 0.5 millimeter, you can't have a patient moving their heads or blinking, or well, they can blink, but we put an actual halo, a frame on their head that locks them into the machine. So we can't have them moving even 1/4 millimeter. So we have to have extreme immobilization, accuracy of a 0.5 millimeter. And the beauty of this SRS, or the Gamma Knife treatment, is that we can reach things that a surgeon's scalpel just can't get to, like brainstem or stuff that the surgeon can't take out. And so we can actually supplement surgery with this beam or reach things that a surgeon can't even reach. And if a patient is actually needing surgery and he's too sick or too infirm or has anesthesia problems or for some reason can't go to surgery, we have an alternative in the Gamma Knife. We also can treat multiple tumors. Sometimes we'll treat up to 12 or 15 tumors in somebody's head if it's metastatic from somewhere. So we can treat virtually any number of tumors. We rarely do whole brain radiation here. Some places do whole brain, but the problem with whole brain radiation is a year or so down the line there can be some cognition problems, short-term memory loss, or you lose your keys, you're just not as focused as you once were. So we we generally avoid whole brain unless we really have to. And the real beauty is it's an outpatient procedure. We normally bring a patient in at 6:30 or so and put the frame on, do an MRI scan, and frequently they're home by 10:30. So all outpatient. I think in 12 years we've had one patient that was admitted, and it was simply because we had to treat so many tumors that it was taking so long. She just wore out, so we let her sleep, get some sleep. Okay, so how does it work? First thing we do is the neurosurgeon gets up real early in the morning along with one of the nurses before I get up, and they go in and put the frame on, and they start an MRI scan or CT. This can be done with MRI scanning or CT. And once that's done and it's approved, then they are transported from the hospital over to the cancer center. That's where the Gamma Knife Center is over at the Singletary Oncology Center. Treatment planning usually takes about 30 to 40 minutes, and the treatment delivery can be anywhere from 30 to 40 minutes all the way up to 8 or 9 hours. We've had cases out to 8 or 9 hours, partly because there may be multiple tumors, and I think Jerry might get into multiple tumors in just a little bit, and sometimes because the sources are just decayed down. The Gamma Knife has, the current one has 201 cobalt sources, and they start off with a certain amount of energy, and every 6 or 7 years or so that energy falls in half. So as you get toward the end of the run of the usefulness of the cobalt sources, the treatment takes a lot longer. So some of these treatments can get quite long. Then we take the frame off after the procedure is done, and then we put 2 Band-Aids on their forehead, and that's it. And they've had neurosurgery, end up with 2 Band-Aids. And so we usually give them a dose of steroids and see them in a month. So it's a pretty simple situation. And so far we've done 944 cases. So that's a lot of cases, and probably 1,400 or 1,500 total lesions, counting, some patients have multiple tumors. So in 12 years we've done 944 cases. And I dare say if someone had done a feasibility study and based it on that, they'd have never bought the thing. So you never know how many cases there are until you have something like this. All right, so this is a professionally prepared slide, you can see. And so this is what I do with my patients when I try to explain how Gamma Knife works, and I think kind of follow along with me. So the way radiation enters the body, it actually starts being absorbed to a certain degree. And so in this is supposed to be a skull, and this is one beam coming in. And so if I'm trying to get 2,000 centigrade to the tumor, then I'll give around 4,000 centigrade. If I just have one beam, I'd give about 4,000 centigrade or rads to the normal tissue. That's a bad situation. You're treating normal tissue more than the tumor. So look what happens if we just add one more beam. Then to get 2,000 into here, I give 2,000 to the normal tissue just by adding one beam. So that's a lot. That's a very powerful thing. Then the third one, if we put 3 beams on, then we're down around 700. So suddenly we have a therapeutic ratio. We have a therapeutic window that we can start utilizing. So to get 2,000 centigrade into there, the normal tissue only gets 700. And that's just with 3 beams. So with 4 beams, it knocks the normal tissue down to 500, and then 400 with, how many is that? 5 beams. The Gamma Knife has 201. So if I put a chart up there with 201 iterations on it, you would quickly see the normal tissue gets almost a negligible amount, while the tumor gets a tumoricidal amount. So we can kill tumors while protecting the normal tissue to a maximum degree. And Gamma Knife is a gold standard for doing that. There are some other competitors out there like CyberKnife and Novalis and Brain Lab. There's a few competitors, but those are linear accelerator based, and they are okay if you don't have a Gamma Knife, but Gamma Knife is far and away the best normal tissue sparing unit. So the beauty of this is we get the multiplication factor of 200 different beams, so it's very sparing, and we can get a massive dose. Like 2,000 rads is a massive dose into a tumor. The control rates doing this are around 85%. So 8 to 9 out of 10 times we will control whatever we're shooting with the beam. So why do we, what are the cases that we use Gamma Knife for? Well, why do we use Gamma Knife? One is you don't have to go into the head and do surgery, so that's a cool thing. It's actually a very low complication rate, and you can see why, because we concentrate 98% of the dose on the tumor and the normal tissue gets almost nothing, so complications are very low unless the tumor is right up against a brainstem or right up against an optic nerve, and we have ways to spare that normal tissue as well. We can treat multiple tumors, as I said before, which is very good, and it's really much, much, much lower cost because there's no ICU stay, there's no anesthesia, there's very little complication rate. So overall, this is a heck of a lot cheaper than a neurosurgical procedure. And we get excellent control rates of around 85%. And like I said, the patient gets through with the procedure, you put a couple of Band-Aids on and they're gone. So we very, very rarely do we get a patient calling back with any kind of headache or any kind of symptom. All right, so there are a lot of things you can treat with Gamma Knife, and we treat most of these. Brain metastases, a single solitary metastasis, sometimes we operate on those if it's really convenient out toward the edge of the brain. Sometimes we do Gamma Knife. If there are multiple, we always do Gamma Knife for those. We can treat primary brain tumors, astrocytomas, gliomas, AVMs. Those are arteriovenous malformations. That's a funny squiggly thing that's a combination of arteries and veins that has a high risk of bleeding, so we can actually treat those. Trigeminal neuralgia, which is a real painful situation where the trigeminal nerve is extremely painful, frequently from an artery that kind of pounds on it. And we can actually somewhat numb that nerve or dull its receptors. We treat a number of benign intracranial tumors such as acoustic neuromas. And then kind of a burgeoning new area is treating Parkinson's disease, the tremor of Parkinson's. That's done in a few places in the world, and even seizure disorders. Some people are starting to treat obsessive compulsive disorders that aren't responsive to anything else. So there are new indications kind of being studied all over. So what I was attempting to do here is show you some before and afters. This is a before, and that's an after. So that shows complete disappearance of that particular tumor. So that's the before and that's the after. So that looks like recurrent tumor, but it's really not. That's just a reaction set up in the brain. So if you ever get a Gamma Knife and we repeat an MRI scan, there's sometimes some confusion about whether it's controlled or not, and we have to sometimes just follow with MRI scanning. That was just a pituitary tumor. Just to show you how accurate some of these have to be. This is a pituitary tumor, and the optic nerve goes right over the tumor, if I could show you in 3 dimensions. And so we're able to treat that tumor and not affect the optic nerves. I don't think we've had a single optic nerve affected yet. We had one with a tumor smushed right around it, and the lady has one field cut, but that's it. And she's about 8 years out. I just saw her yesterday, so that's a wonderful thing to be able to do. Just show you another small tumor that's that we're able to control with this technology. So the new Perfexion unit that Dr. Kadis is going to talk about still has the same precision of 0.5 millimeters. The number of cobalt sources are reduced just for technical reasons to 192. And there's a lot of other, I think you're going to go into the advantages. So there are a lot of other advantages that make it technically a lot better machine. So we thought we were dealing with a Cadillac, but you know, all the new cars come out and they're better. So any questions that have been spurned, you can ask now or save them for Jerry. So I'll turn it over to Dr. Kadis, and he's gonna show you the new thing.
Well, I've got the fun part. Steve's done the heavy lifting. He's basically taught you how the machine works, what it does. The new machine does the same thing, but it does it in a different way. I kind of think of the old machine, that's the C unit there. You can see it. I kind of think of it like, you know, a nice VW bus, because it would take you from A to B, but you had to shift gears. It was kind of a constrained and somewhat uncomfortable machine for a lot of people. So I think of the new machine, it's kind of like a Rolls Royce with a chauffeur. And I'll explain to you why that is. This is the new machine here. It's a fully automatic machine. With the old machine, we had to change the helmets. There was a lot of mechanical interaction between the team, and I mean the team, that's Janet, Ramesh, myself, Steve, Dave Saunders, and Craig Fredericks, the other neurosurgeon. So we've had a stable team for the whole time that the C unit was in place. And let me just show you the C unit again. In the C unit, you had these helmets here that we had to change. They were for different size shots. So we had a hydraulic lift that came off the side here, and we had all the helmets arranged and for different size shots. And we used many shots of different sizes. You had to mechanically remove this 300-pound helmet with a hydraulic lift and put on another helmet. And then the positioning system was attached right here, so the patient's head would be the moving part. Because what was inside here was fixed, so we'd basically move the head in 3 dimensions to bring the tumor into the epicenter of the focused gamma rays. You understand? So this worked beautifully. I mean, we treated over 1,000 brain tumors, and it worked great. And the new machine does basically the same thing, but it just does it better, and it's automated. And it handles a lot of other issues that we had. For example, the old machine was designed for the typical Swedish-looking person, a long neck, small head, narrow shoulders. We had trouble with these patients, and we got a lot of these folks down here. No neck, huge shoulders, big head. The difficulties were, you know, moving them inside that automatic positioning system was very, very difficult. And it required a lot of acrobatics amongst us to be able to treat tumors in various parts of a person like this. You know, it was really difficult. So the new machine, as you can see, this is the opening for the old C unit right here. It was like this. So this was the helmet, you see. And then we had this positioning system that attached. So you had a lot of physical constraints with the old machine. But here's what the opening to the new one is like. I mean, it's by comparison, it's huge. I like that music. Is that you? Nice. We get to dance a little bit here with that. Okay, so the new machine is designed and it handles different body types better. The guy with the bull neck and the big head and the broad shoulders, we don't have that problem with this new machine that's actually getting installed next week. So we're very excited about that. So this is a side view of how this new machine looks. It has all the different beams that you had with the old one, but housed in this tungsten housing are little motors, and I'll show you a video at the end as to how that works, so that there's actual movement going on inside the machine that brings the different beams into play. And it's really a fantastic engineering feat. So the new unit is fully automated. In other words, we got a chauffeur doing it instead of us shifting the gears, changing the gears around. So it's pretty remarkable. And the other thing is you've got this improved patient comfort because the whole unit is so much more comfortable. I actually got to go into one of these when I was in Sweden a few weeks ago learning how to use it. They had a unit there that was, didn't have the cobalt sources in it. So I went into the machine myself to experience it, and it's very comfortable. It's cavernous space. The mattress is very, very comfortable mattress. And it's a very comfortable experience. I mean, you feel like you're in a lounge. So it's pretty nice. So the difference here, though, is that this is the new unit here. So the patient's head is attached to the frame, but the frame is attached to the bed. You don't have this robot issue. And the couch here, which is actually manufactured separately from the main device. These are manufactured in two different places in Sweden. So the main housing unit and the couch, they don't even meet till they come to Thomasville. And then they're assembled and put together. But the couch becomes the positioning system. There was the patient's attached to the couch, and the whole couch moves in 3 dimensions with an accuracy of 1/10 of a millimeter, which is pretty miraculous. So you've got the couch that's moving in 3 dimensions to bring the tumor into position inside here, and then inside you've got the sources that are being moved to give the different shapes and sizes of the dose that we want to give. So I'll show that all in an animated video in a minute. So here compared to the old C unit, where the head was attached to the helmet and the automatic positioning system moved the head separately from the body, which was uncomfortable, and we had issues with collisions sometimes where the patient's head would want to collide with the helmet, or shoulder would be biting into these robot positioning arms. I mean, the effect was the same, but it was just very much more uncomfortable. Okay, so what I'm going to do next is I'm going to show you a video, and I'll stop it part way through, as we go, so you'll see how that works. See if we can get the video going here. All right, can everybody see it? Okay. So this is a kind of an animation that shows how the new machine looks and how it works. And what I'll do is see if I can periodically stop it. Let's see. I guess I'll have to stop it up here. But you see here, this is the patient going into the machine. And you can see it's a very comfortable mattress and coming out. And the control station is quite more simple, and you can actually have glass between because there's so little scatter of radiation in this new machine that you can actually have glass window to view the patient. That's another point, is this new machine has very little scatter radiation, so you can almost walk into the room, even with the doors open, to the sources and not be worried about getting radiated. So it's the patient's positioned in here, and then what's going on the inside you have these sectors that are moving, that move the radiation sources into position. And the motors that drive those sectors are the only part of the machine that's not made in Sweden. Those motors are actually made in Italy. Apparently they're extremely reliable, and the Swedish people didn't feel they could make those motors. But I mean, the engineering that goes into this is truly phenomenal. I mean, it's a wonder, this machine. So this whole housing and the couch are made, like I say, in 2 different parts of Sweden, and then they come together when they're put together here. Let me see. Get that back again. Oop. Get back here. All right. So these, and So we're going to see how this all comes together in actually treating a model of a tumor here. You can actually shape these beams, which we couldn't do with the old machine. It gives us tremendous flexibility. So you can see how the different collimator sizes are up there. And all the beams, the 200 and so beams, all come together. And see, that comes together at the epicenter there. And there's a tumor right there that all these beams are focused on. And then fully automated movement to the next position. So the patient has another tumor here, for example, adjacent to the brainstem. This can be picked off with tremendous precision. And what we mean by picked off, the way the gamma radiation works, it disrupts the DNA in the tumor itself. So the DNA gets disrupted and stops replicating. It's basically how that radiation works. So it stops the tumor from growing. In some cases, the tumors just disappear, and some they just stop growing, and which is just fine. So you can see we do different shots, different sculpted shots to treat each part of these individual bits of the tumor, like that. So you can have multiple targets, and due to the fact that it's so automated, the time between the different shots is in seconds compared to what we would have before, which was in minutes. So the speed and the precision is tremendously different. So that gives you an idea of what that new machine's doing. Let me cut it off, but it wants to do it again. We're very excited, naturally. I mean, I'm bouncing around. I can't wait to get started with it. They tore out the old machine this week, and the new machine's going to be in place fairly soon. And then it has to go through a whole series of checks and balances with the physicists, and then we hope to be up operational beginning of October. So we're very excited. It's tremendous technology, phenomenal machine. Anybody have any questions for me? Yeah.
How much does a machine like that cost?
Millions. It's millions. It's very expensive, as you can imagine. And then, well, just installing it is huge. I mean, this is a 20-ton piece of equipment. And it's interesting, the actual cobalt that's inside of it only weighs 20 grams. But that's the active component. But it's housed in a 20-ton, very sophisticated piece of engineering. So just getting it in there is a chore. I mean, it takes a whole team of professionals and engineers and physicists to put it in there. But it's millions. It's a big investment. But we feel it's worth it because you could have this done in Atlanta. You can go to Augusta, or you can go to Jacksonville and have this done. And the treatment is uniform throughout the world. It's the same treatment protocol. There's really no difference whether you get treated in Thomasville, but you don't have to drive and risk being killed on the highway going to Atlanta, to have the treatment. And the beauty of the treatment is it's done in the morning, and you go home and have breakfast, and you're done. It's treated. It's done. It's not a come back and get another dose another day. So you come in, you get treated, you go home and have breakfast, literally. That's how it works. So it's very convenient, and yeah.
In time, can it be used for other tumors, like maybe liver or somewhere like that?
Well, there is technology developing, and Dr. Johnson can answer that. But yeah, there are great efforts being made to be able to go to other, and he has machines that can do that.
We already have that.
Yeah.
It's a linear accelerator based. We have a linear accelerator named Trilogy that when you do it for the rest of the body, it's called SBRT, Stereotactic Body Radiation. Mm-hmm. That's the acronym for the precision, and you usually gate it related to people's respirations, because in a lung tumor or a liver, things move as somebody breathes, so we teach them how to breathe, and so it's a real sophisticated thing. But compared to Gamma Knife, it's crude compared to the Gamma Knife 200 beams. We use a rotational kind of thing with the linear accelerator, and it's really good, but it's not Gamma Knife.
Can you treat the lungs?
Yes. Mm-hmm. Yeah, with the SBRT, we can, for the patients that can undergo surgery, they may have COPD and can't tolerate surgery, we have about a 90% control rate treating any tumor that's less than about 4 centimeters, 3.5 centimeters or so. It's very high control rates, and it's only 4 treatments instead of the usual 6 or 7 weeks of treatment you hear about. So that's a huge technology for us. So we have a lot of lung cancers down here, a lot of smokers.
Yeah.
This machine in any way help Parkinson's?
Well, Parkinson's is a very complex machine problem. You've got a series of things. You've got bradykinesia, which is slow movement. You've got tremor. It's a complex problem. The thing that Gamma Knife is now being used for is essential tremor. That's a burgeoning area, and that's a different kind of a tremor. It's a steady tremor. It's not associated with bradykinesia or the other retropulsion issues that are seen. So let me put it this way. We're excited about potentially treating essential tremor with this. The results are good thus far. There are several places in the world that are using it for it quite successfully with very few side effects. Parkinson's is a much more complicated illness, and I think the most promising treatments surgically are the deep brain stimulation treatments that are done in a few isolated centers, and of course medications. But essential tremor looks like it may be something we may start doing here in the future when it's been proved efficacious with few side effects. Yeah, Jimmy.
Jerry, as you come down from the brain now, can you come down the spine some and treat the blow?
Yes, we can get a little lower with this machine, as you can imagine, because the physical constraints of the old APS and the shoulders are not present. So we can actually get the patient further into the machine so that we can treat a little bit below the foramen magnum more comfortably. I mean, we still don't go much further than the upper cervical spine with this. Yeah, that was another question. Yeah.
Two-part question. What type of anesthesia is being used while these patients are traveling through this remarkable machine? Part two is what type of seizures is possibly being treated?
All right, answer the first question. Patients get a little local anesthesia when we attach the frame, and that's it. You're awake, listening to music in there. It's just as comfortable as can be. We have music that plays for the patients. They're awake, they're comfortable. You don't need any anesthesia for it. Now, if you were doing a young child, which would be a frightening experience, then general anesthesia would be given for that. But for the average person, just a little bit of numbing medicine. If they're very anxious, we may give them an anxiolytic, a little Xanax or Ativan or something in advance if they're very anxious. But really, it's a painless undertaking for the most part. Yeah. Any other questions? Yeah, good. Yeah. Okay, she wanted to know what sort of anesthesia we used while we were doing this, and I told her there is none really. A little local anesthesia to apply the frame, but the procedure itself is painless. In fact, we play music. The patients have the opportunity to bring what music they like to listen to, and we play it for them while they're in there getting the treatment. Or they'll have to listen to what we want to play if they don't bring their own. So. Yeah. Any other questions for Steve or myself? Oh, good. This is wonderful. Yeah.
This hip leg harder brain tumor.
I don't know what he's got, unfortunately. I'm not involved in treating him, so I can't really tell you. But, we've...
got a melanoma.
Oh, does he now? See, Steve knows. He's involved, so I don't know. I didn't know
It's
that.
metastatic. We were talking about it the other day. It's
Oh, okay.
metastatic to the brain, like 3
Okay.
or 4. Here, he would definitely get Gamma Knife.
Yeah.
For melanoma, it's actually really good for that because melanoma tends to be pretty resistant to standard doses. So these are very high doses, so you can overcome the shoulder on the curve, is what we call it, and you get into the dose that'll actually kill a tumor. But he's also got it in his liver, evidently. Now there's some new immunodrugs, some monoclonal antibodies that are actually working well with melanoma. So it could be that if he got Gamma Knife and some of these newer drugs, he could live a long time. You can, if he gets lucky. So we would do Gamma Knife. I don't know what they're doing for him. He might be getting Cyber Knife. Have you heard of that?
I don't know.
He's been treated at Emory, so Emory has a Gamma Knife. They just bought St. Joseph Hospital that has one, but he might be getting linear accelerator based, which just goes to show you,
Yep.
they have one, and you know, he's an ex-president of the United States. He's not getting as good of a treatment as
Yeah.
any of you would get here. So that just goes to show you,
It's interesting, yeah.
See, it's not.
Yeah.
It's the institution doesn't treat you.
Yeah, there's a lot of politics involved in what kind of treatment you get. I was shocked when I went to Stockholm, Sweden, to find that they only have one Gamma Knife in the whole country of Sweden. There's a lot of political situations that they have competing types in other parts of Sweden. But when I took my course there recently, there was another neurosurgeon who was going to get one in Uppsala, Sweden. But there's a lot of politics involved in how someone may or may not be treated. May not always be the best treatment.
Now, one little anecdotal thing, when Jerry and I went up to Pittsburgh for our training in '03, there was a neurosurgeon from London who was doing that. At the end of the first year, we had treated like 80, maybe. He had treated 13. So they had some fairly strict selection criteria.
Right.
That we
Socialized countries work a lot differently. Good question.
About seizures,
Yeah.
how does Gamma Knife help with seizures, and what type of seizures?
Yeah, seizures are a much more complicated issue than you would just approach with a Gamma Knife. Now, there are some groups that are treating mesial temporal lobe epilepsy with a destructive dose of gamma radiation to the presumed area of seizure that they've documented has the focus of the seizure. But generalized seizures, as a rule, are not being treated with Gamma Knife alone. No. Anybody else? Question? Good questions, everybody. Yeah. Yeah, go ahead.
A couple of questions.
Yeah.
What are some of the symptoms that a person might experience that would indicate a tumor? And from an insurance standpoint, does Medicare, that must be a very expensive procedure, I'm
Yeah,
sure.
actually, most insurance companies prefer this kind of treatment because it's a lot less expensive than the ICU, the anesthesia. That's why China just recently bought a whole bunch of these, didn't they, Ramesh? I don't know how many they bought. 25. Yeah, it's a big country.
They bought it with US dollars.
There's a bulk buy there, 25 Perfexion units. Can you imagine? But yeah, the last one's free. But Medicare does pay for this, and in fact, most insurance companies are happy to do this because it's cheaper. But the symptoms you asked, now, the symptoms are depending on what kind of tumor and where it's growing. It can be as little as a little dizziness and minor hearing loss with a small vestibular schwannoma, a tumor that originates in the ear canal. Or it could be something much more. You know, if it's a big tumor, it could be paralysis or weakness or headaches. I mean, we see it all. You know, depending on where the tumor's growing, what kind of tumor it is, symptoms will vary. Yeah, go ahead.
This machine, does it treat anything, or do it work on the brain?
It is strictly for the brain. This is a brain instrument. We don't treat anything else but the brain with this. In our old C unit, we treated over 1,000 brain tumors. This new unit, we expect to do as much, if not more. Yeah?
It was unusual to hear glioblastoma back in the day, but now it's like we're seeing it often. What do you attribute the rise to?
I don't think anybody knows. I don't think anyone's pointed the finger, you know, as to what it is. I don't think anybody knows the cause. Yeah, another question? Yeah.
Yeah, and the source, is that, how do you retain that and protect it from the
Great question, yeah. The radioactive cobalt, you see, is housed inside this tungsten shell, which is thick and huge, and the radiation can't get through that. So it's in little capsules that are moved in front of these orifices, which are channels inside that tungsten helmet, that thing. And then it goes through there, down the channel. But when it's not actively being used, it's moved to a position where it's inactive. It can't get out. That's the way I can explain it. But you're right. If you just took that stuff out here and put it out here, we'd all be cooked in a matter of seconds. So that's why there's a lot of control over this. It's a very powerful material. So it has to be very carefully controlled and looked after. Radiation safety is a whole...
Security is on campus now.
Oh, yeah.
Because of these sources.
Oh, yeah.
So it's a lot to cover all.
Yeah. And I think we're supposed to be getting retina scans before we go in there now.
I'd
So
like to mention there's going to be a test over all this too.
yeah, before you leave,
Actually, it's handing out the papers.
we'll see what you retained. Any other questions? Yeah.
Just back in '96, you took a pituitary tumor off my brain.
Great.
If it happened today, this is the procedure you would use?
It depends. If it came up today and we had enough clearance between the tumor and the optic nerves, which are very sensitive to this kind of radiation, we might very well treat it with the Gamma Knife. Yeah, that's good. Yeah. Anybody else? Yeah.
What happens to the old machine? Does it go to somebody?
Would you like it? No. It gets, well, Ramesh could probably tell us better what happens here. Scrapped. And I'm sure the sources are carefully.
It'd be a hell of an anchor for a boat. Got 5 big.
Yeah.
Patients have some claustrophobia, typically this machine.
No. This is not as confining as the MRI machine. In the MRI machine, you get moved into a tunnel. So we occasionally have some claustrophobia issues when we're doing the MRI beforehand. But in here, they don't have a problem with it at all. It's very spacious inside there.
Most people sleep
Yeah,
during
comfortable.
the procedure. They just
Right.
wear and snoring or
Yeah,
play soothing music.
right, yeah. Yes?
You think you can get us a bigger, wider scanner for MRI?
Yeah, that's right. That's the future, isn't it? When the way we're heading, we need bigger and bigger. Though our newest MRI has a bigger gantry.
Yeah.
So it is better. But I know, you're quite right. The bigger, it seems to be job security for all of us there and larger patients. Yeah, go ahead. Anybody else? Well, great. Oh, go ahead. Yeah.
While you working with this radiation, do you have to have a dosimeter in there to let you know how much radiation that your body is receiving? Because I know you're not allowed to work for so many
Right.
hours in radiation.
Right. That's a great question. And that's a great question. And for most of the radiation areas you do, but this new machine, there is so little scatter that we can treat pregnant patients in this machine. You can take someone in their first trimester of pregnancy, if it happened to have a tumor, and safely treat them without worrying about the minuscule amount of radiation that escapes into this room. So it's very, very low scatter, even with the doors wide open. It's amazing. Yeah. Yeah. Defibrillators become an issue when we have to do the MRI. So we use CT. But the defibrillator in this machine is not an issue at all. No. And the nice thing about gamma treatments, we can treat patients that are in renal failure, that have all kinds of cardiac issues, be on blood thinners, Plavix, all the hundreds of blood thinners that are out now. We can treat them in the Gamma Knife, no problem at all. So we have very few contraindications for doing these treatments. I mean, it's very safe, and you can treat patients that are very, very ill. Yeah?
How often do you have to have this machine calibrated?
That's for our nuclear physicist, Ramesh.
Once a month? Okay.
Yeah. Yeah, there are protocols in place for all of that. Yeah, that's a good question. Yeah.
Do tumors tend to grow rapidly in most cases, or does it vary? And is there a backlog if you were to have a tumor?
Right, that's a great question. Different tumors have different rates of growth. For example, the vestibular schwannoma, which I mentioned earlier, occurring on the vestibular nerve in the ear, is very slow growing. Very slow. I mean, its growth rate is in millimeters, per month. Whereas other tumors that are more malignant have a very rapid growth rate, completely different. So it really depends on what it is. Yeah.
But there's no backlog.
No background.
No,
we
no.
have a lot of capacity. We can do 3 or 4 a day if we had to, so.
Yeah. We don't have anybody on a long waiting
No.
list. Now, we have got a few people waiting for the new machine.
Yeah.
Yeah, but these are all slow growing too. We've got a patient with an AVM that we have to treat, and several vestibular schwannomas, a couple of trigeminal neuralgia patients that are waiting for the new machine. Yeah.
Can you determine, who determines if you have a tumor in the ear?
Yeah, well, usually that most of the ones we get, and we get about 8 per year, are picked up by ear, nose, and throat surgeons in the course of investigating hearing loss. They'll get an MRI and see it there and send it to us, and it's a great way to treat this tumor. Much, much easier than open surgery, and a lot safer and very effective. Yeah.
Where do I go to get a point, man?
You want to get a Gamma Knife?
If I need a point and I want one, where do I go?
Oh, well, usually what happens is your doctor that diagnoses the tumor will send you to one of us, our group, yeah. That's how it works. Any other questions? Yeah.
You say there's not no scatter.
Right.
No,
There's no scatter radiation in the room.
how do you know that?
They measure it. They have techniques to measure. Dr. Nair has tools that you can use to measure the amount of radiation present inside the room at any given time. Yeah, but there are very sophisticated instruments that can measure the amount of gamma radiation anywhere. Yeah. Other questions? Well, this has been great. One more, yeah, go ahead.
We have a pacemaker and a defibrillator. Could you be put in?
Yes, no problem. Now, you would have we'd have to use a CT scan to, because we couldn't put you in an MRI machine, but we could do CT, and that's perfectly compatible, no problem. All right. Well, thank you all very much. Thanks for coming out. Good.